Welcome back to Favaloro Foundation University Hospital. We are here at the lab number 1. On my right side is Dr. Carlos Fava, as always, Dr. Joaquin, our fellow, our nurse, Matias, technician, Christian. Behind the control is Hernán and Gustavo, and Dr. Rodriguez is following the questions that he will bring the question from the audience to us. We have the chief of echocardiography today, Dr. Salmo, joining us for this case, and Dr. Jaime as anesthesiology. So we will present the case. Let's see with the first slide. This is case number 13 for this terrific project. Once again, to thank Dr. Samir or all the director of MedStream for inviting us and to join this terrific group of colleagues doing this educational project. Next. So she's a 76-year-old lady. She's presenting with dyspnea and also an episode of pulmonary edema on May of this year. She has history of hypertension. She suffered from a trauma 2 years ago with lung and splenic perforation requiring surgery for both areas. And also she has a bilateral knee replacement. She needs a walker for walking. She also had a history of coronary artery disease with a previous PCI on the right coronary artery in another center some years ago. After this surgery that I already mentioned, she suffered also from a paroxysmal AF. So she's under anticoagulation. She has a chest box little bit high with the highest bleed of 3. So it's something that probably we should discuss after the procedure of what to do with the anticoagulation. Next. So she has a normal ACG on a normal sinus rhythm with normal PQ, blood tests that are almost normal with a little anemia. The echo Doppler show the severe aortic stenosis. Dr. Salmo is going to show the echo he did before the procedure here in the lab. She has a preserved left ventricular ejection fraction. The area is 0.4. She has a moderate frailty and is, according to our team, is not fertile for a TAVI procedure or aortic valve replacement. Next. So this is the coronary angiography. You see a long stent on the right coronary artery with the tight stenosis in the distal and edge and moderate to severe on the proximal edge. Next. So there is calcification on this area. Next. We also observe the calcification of the aorta. Next. This is the left coronary arteries. The left main is very short, with a moderate, or middle left coronary artery. So the left main is too short that it's almost impossible to engage bilaterally. So in this first marginal branch, we observe a very tight stenosis. It's a huge marginal branch. And then we have calcification on the proximal segment of the LAD with a tight stenosis of this long and big first diagonal branch. Next. This is on the spider view where we can see this tight stenosis on this big first diagonal branch. So this is the arteriography where we observe initially a highly angulated annulus, aortic annulus. Next. This is the CT scan showing a 13 by 25 millimeters diameter on the annulus with a perimeter derived of 22. The perimeter is 70.4 millimeters. The area is 354. The ostium heights are 15 for the right and almost 15 for the left too. And the angulation measured on the CT is only 33, but according to the angiography and also on the echocardiography we have done here, it seems to be a little bit more than 33. Next. The LVOT is a little bit bigger. This is the annulus and also the sinus of Valsalva of 33 with significant calcifications. Next. So this is the LVOT, a little bit bigger with an area of 360 or something like this. And the sinotubular junction of 27. Next. So this is a view of the tricuspid valve with the significant or heavily calcification of the 3 leaflets. So in this case, we are going to predilate, although for most of the cases where we are using balloon expandable valve, we don't. But in this case, I think due to the calcification and also the angulation, I think it's much better to predilate at least with a nominal balloon. Next. So this is a sinus height for the left, once again, 14.8, for the right, 15. Ostiums are big and also distal to the sinotubular junction with big sinus. Next. This is the angulation, and here is another measurement, where the angulation is 63, is in concordance with our observations on the angiography. Significant ventricular hypertrophy and not significant calcification on the ascending or aortic arc. Next. So this is the implanter's view, but for right and left cusp overlap view, it's going to be left anterior obliques 12 and caudal angulation of 28. Next. So these are vascular access. The right femoral access is a huge artery without significant calcification, a little bit tortuous, but not too much. The angulation, the bifurcation of the aorta is a little bit tight, but it was not too difficult for crossover. Next. So this is the left, which could have been also a potential for vascular access, but we have chosen the right. Next. So in summary, she is an octogenarian with severe symptomatic coronary artery disease and severe symptomatic aortic stenosis. She was presented to the heart team, and the suggestion was doing PCI to the right, to the left, the circumflex and the diagonal, and then to proceed with the TAVI implantation. So let's, the patient has already undergone the PCI procedure, which I will show you because it's in a way interesting. Next. So we use a regular wire by a radial approach, probably right or wrong, I don't know. We decided to use a nominal balloon with the stent. The stent implanted was 3.0. We used a 3.0 long balloon for predilatation of the whole segment. Next. But after this predilatation, we have this significant perforation. So we decided to, at this moment, immersion the enclosure of the vessel, inflating the balloon that we use for predilatation. Next. So this is the type 3 perforation of the old Ellis classification. So we have a perforation of the adventitia. So we have a pericardial effusion. Next. So this is once again, the classification to remember from Ellis classification is a perforation type 3 with extravasation through the frank perforation, more than 1 millimeter perforation. Next. So for this situation, you have to correct very quickly. There is a very nice algorithm, the Euro intervention that you can review there. It's a Euro intervention 2014. And for type 3, we have to consider to correct the coagulopathy. I mean, platelet transfusion or something like this. This is not the case for the patient. And in my opinion, it's not any reason to correct the anticoagulation, because if you correct the anticoagulation, probably you will have a stent thrombosis or something like this during the procedure. And if you have a huge perforation like here, you have to consider balloon inflation to check if it's not working, to use a cover stent. And in the worst situation, surgery or coil embolization of the artery. Next. Of course, all these procedures should be controlled under echo. This is the algorithm published by Francesco Cianini in SHAC in 2018. And we have a right coronary with a significant perforation. And we decided to use the ping pong technique. We use a second puncture. While the balloon was inflated in the right coronary artery, we introduced a second guiding from the femoral artery to treat the patient. while the patient was protected, I mean non-bleeding, during these maneuvers. Next. So this is what we did. We introduced a second guiding. We cross when we deflate for a second. We cross with the second wire in the vessel. We inflate the balloon inflation again, and we prepare the cover stent to be introduced by the other guiding while the balloon was inflated there, preventing to keep bleeding this perforation. Next. So here is what we did. So meanwhile, we have a 3.0 balloon inflated. We deflated for a second. We cross with the second wire through the second guiding introduced from the femoral. Next, and then we, as you can observe there, the long inflation was not sufficient to fix or to seal this perforation. Next, the patient was still stable, and we decided to use a 3.5 by 22 cover stent, leaving the wire behind the stent of the first guidance just in case. And as you can observe there, there was a complete sealing of the perforation. It was not necessary to recover or to, to revert the hyperonization. We checked by echo next. There was a significant pericardial effusion that you can observe there below the wire. So we did a pericardial puncture, and we introduced a 6 French sheath with a 6 French pigtail, and we aspirated 250 cc's from the pericardium. Patient was stabilized. The patient was completely stable. We did a test with the pigtail and also with the echo to be sure that all this blood was evacuated from the pericardium. Next. So the patient was transferred to the CCU. She stayed there for 2 days. We retrieved the pigtail from the pericardium the following day. And 3 days after the first procedure, we decided to proceed with the remaining lesions on the first marginal and then the first diagonal branch. Next. So this is a long stent on the first marginal. And then using 2 wires to protect the LAD, we pre-dilated the first diagonal branch. To be honest, we were a little bit scared about the perforation once again, because this lesion was much more calcified than the right coronary artery. Next. And then we deploy the 2.5 by 23 drug-eluting stent, trying not to protrude into the diagonal, into the LAD. As you can observe there, this mild lesion distally to the bifurcation. So we decided to leave it like this. And this is the final result. The patient was discharged the following day. So she stayed in the hospital for 4 days after this initial complication. Next. So this is, once again, we did a post-dilatation. Next, let's go. And so today we are prepared for TAVI. We thought to prepare this patient for percutaneous femoral access. And due to this angulation of the aorta, we thought about of using a balloon expandable with a deflectable catheter for this TAVI procedure. So next. So she has an area of the annulus of 354 or something like this. So it is in the range of the 23 valve, as you can observe there in the green column. No, let's go back there. It's okay. So for number 20, the Sapien number 20, if we use 2 cc, it's about 10%. But if you use 3 extra cc's, it's 17. So it's a little in the borderline of the 23. With -1, it's going to be 7. So we decided to use the 23 minus half of the centimeter. So it's going to be about 8, 9, or 10% oversizing of this annulus in a big calcified artery. So now, yes, let's go back to live. So we have prepared here We have done the crossover. Maybe Dr. Salmo, could you show the echo before?
Okay, this is
Let's
the
show
echo.
the echo before.
Yes, this is the echo before procedure. As Dr. Mendy told us, this patient have a severe aortic stenosis with a peak gradient of 68 and mean gradient of 45. This patient have a normal ejection fraction, a little mitral annular calcification with mild mitral rotation, and this is the pulmonary artery pressure. It's about 45. And another thing this patient have is a mild aortic regurgitation in this view.
Okay. Thank you so much, Fabian. So we have, let's go to the ancho. We did a crossover. It was easy to be done with the pigtail, with the regular wire. But then we end up into the profunda. Next, let's move with the anchos very fast, people, uno y otro. So we decided to reposition in the catheter. Next. We use an hydrophilic wire to go to the superficial, and then we leave there along 018 wires. You know that probably we are too old, but we still leave these wires contralateral. Actually, yesterday we did 3 cases. In the last one, we have a significant bleeding, which was very easily to control by contralateral side using cover stent. So here we are now. We have an 11 French sheath on the right femoral in the vascular access, because we were waiting for life for 30 minutes. It's not ideal to have a huge sheath in. So we have an extra stiff wire, and we are going to introduce the sheath from Edwards here. Meanwhile, as always, I invite to everybody to write questions. Dr. Rodriguez is going to bring to us, and if we can, of course, we will try to answer. To introduce this sheath, it's important to hold it because there is not a lock. Date vuelta, Joaquín. Tenela aquí, so Carlos is holding here, because if not, it disconnect one from the other, and you can damage the artery. So now, leaving the wire in place, I'm gonna pull the introducer, and then I'm gonna fix it because it's a hydrophilic catheter which is gonna move during all the procedure. I have a thread here that I will use to fix the sheath to the skin, just to prevent any kind of movement. As the patient has a normal ACG, our intention is not to use a right ventricle pacing, just we are going to try to pace through the wire. But if we were checking during the pre-dilatation, if we are not comfortable with this, we of course can change, and we can put a pacing wire on the right ventricle. So now I will try to cross. We still have 35 minutes, but I think it was important to show this complication of the PCI, which was unexpected. And also it's important to show how we manage to solve this situation in a very, complex patient, because the patient with a significant coronary disease, also a very tight aortic stenosis, she's not gonna be, a good patient to tolerate a significant pericardial effusion. I will try a couple of seconds, as always, with the pigtail, but we have a Lamplats catheter prepared to cross using the regular way. Because it's a very angulated aorta, I think I'm not gonna be able to cross with the pigtail. And also I don't want to spend too much time. Let me try. It's very tight and very angulated, so it's better probably to go in the regular way. Yeah. Yeah. Perforation. Yeah. And okay. So the question is how we manage the anticoagulation during the perforation. As I told you, from my point of view, it's important not to revert the anticoagulation, especially when you have deployed the stent. You have to fix the perforation. I would say to revert the heparinization is probably the last things to be done. Long inflation would save most of this perforation, but if it is too huge as like this, you have to be ready to deploy a cover stent. Cover stent should be in any cath lab doing complex PCIs. We have 2 branches here in Argentina. Probably there should be some more, but we don't have preference of any. It's just the stent, you have it. Any other? Yeah. Yes, it could have been delivery. The question is if the cover stent would have been delivered without the ping pong technique. Yes, of course, it could have been, but the problem is that meanwhile you are working, preparing, entering the stent and so on, you have a significant bleeding there. So it's better if you can have the ping pong technique because you don't have bleeding during these minutes. Let's go to the oblicua izquierda, people. Let's see. This very tight stenosis. Probably we need the amplats a little bit bigger. Any other? Let's go to la oblicua derecha. Yes. The question is if I don't like it where I am crossing. Let me see. To be honest, I don't like too much. Let me cross again. Not sure. Yeah. You see how tight is the stenosis? Let me test there. I don't know. It seems to be. Okay, we are crossing a little. Give me the J. Once again. Sapien 3, it is supposed to be better for coronary protection because we don't have a too high crown. We have a big cells in the proximal part of the valve. You see how difficult it is to cross? So probably we should use the amplats wire here. We have to take time. I scare a little bit of how we can cross with the valve. Okay. Show me the catheter. Now we are in a better position. Give me the amplats. Okay. To be honest, I don't remember a case with such a difficult for crossing in the last month. So we are repositioning the catheter distally with the amplats. We are okay there. Now I feel better. I think the position is better. I think we probably cross between the commissures, but near to the septum. But now we are in a better central position. I like it more. I like it, I like this position and not the other. Let me go with the pigtail. Any other question, Andres? coronary PCIs. So the question is if we are doing young patients, low risk PCIs. Well, it's not that common, but of course, sorry, aortic stenosis. Sorry about that. No, low risk patient with the young patients with low risk, we are not doing. It's not, allowed. I wouldn't say allowed, but it's not reimbursed in Argentina. And actually, I don't agree to do TAVI in a case below the 70s if we don't have a clear clinical indication for that, because we still have to learn about the durability, which is, I think, still the only or one of the few limitations that we have to do TAVI to everybody. The limitations are two, I think, durability and probably the cost, especially for countries like Argentina, no? So we are going to check the gradient, people. So that's why we couldn't cross with the pigtail as always, because it was too tight. Going back to the question, we have done young patients, but no low risk. The younger patient we did, it was a lady with 34 or 35 years old. The patients who received a Ross surgery some 10 or 14 years before, and then she had a complete calcification of the ascending aorta, the annulus, and the LVOT. Everything was fixed. For surgeons, the only solution was heart transplantation. So we decided, not the Landerquist. We decided to, no, it's okay. It's okay this way. It's okay. We decided to do TAVI, and the patient is still doing okay, but probably in the future, she might need heart transplantations due to all these, comorbidities and all these situation she has in this LVOT due to this previous surgery. She's also under renal dialysis from peritoneal dialysis. So she is a very complex lady. But this is the only case. That's why I remember her. And going back to the question about the anticoagulation and antiplatelet therapy for after the perforation. After the perforation, when we fix it with the covered stent, we went back to the dual antiplatelet therapy as any other patient. And ideally for this patient is to have treatment for a long time, because endothelization of covered stent is going to take a lot of time. So we are going to predilate. Carlos is going to pull the catheter, leaving the wire in this position, Carlos. We haven't done the initial angio. I will do it before predilatation. Vamos a ir a la posición de trabajo. Let's go to the working position, which is supposed to be here. To be honest, I don't like it too much, but zoom. One zoom. Okay. Soltámelo un segundo. Okay. Let's see. I don't like it. Let's go a little bit more más AP. We don't have a... No. No le saques. Ahora. There. I think there we have a better overlapping of the right and left cusp. So we are going to use the Edwards balloon for predilatation. Pupil is going to pace in at 180. Espera. Tené el marcapaso listo porque veo un bloqueo rama izquierda ahí. Well, crossing with the balloon it was, I wouldn't say so difficult. We are connecting to the wire, facing. No, we don't have a perfect pacing there. Now, yes, dale. Prepárate para desfibrilar porque me parece que... Okay, deflate. Take it out. It's okay. It's okay, it's okay. Está bien. Acá, Carlitos, dejando la guía ya bien distal. Yeah. So we have prepared the 23 with half of CC less, which is going to be about 10% overlapping. So be careful. Valve is coming. Mariana is here. Mariana has already prepared. She's from Edwards. Thank you so much for your help. Carlos is holding the wire. I'm going to introduce the valve. I have to push a little bit. Soltame un segundo la camilla. Okay. Here in this position, I can see the valve and also the wire. The valve is going to be out of the sheath now. So it's okay. Now Carlos is going to push the wire. I'm going to retrieve the balloon. Empuja la guía. Okay. As much as I can until the white marker. You show my hands. It's okay. I have the white marker here. And I locking again the device. So now I'm gonna go with a small movement with this torque. Carlos, push the wire a little bit. I'm going to introduce the balloon inside the valve. So I will check it in a better projection. Probably the valve is a little bit into the sheath. Let's check más izquierda. Here, okay. So here we see that the position of the balloon is okay. We see here much better. So volvé, Pipo, ¿dónde estabas? Let's go back. Over position. La última, donde hicimos la última inyección. Esa. 0, which is AP and 15 caudal. Okay. Mostrame arriba. So I'm gonna torque deflect the catheter. Mostrame. Arriba, arriba, arriba. Up. How is navigating this very tortuous aortic anatomy. I'm gonna torque deflect the catheter a little bit more. You see. And now, mostrame más abajo. I'm gonna cross the valve very slowly, very smoothly. I think the position is okay. Anyway, we still have some movements to be done because we, excuse me, Carlos. I have to unlock and to retrieve the deflectable sheath until the two markers. Trying not to move the valve, which is almost impossible. I will take deflection out. Have to pull a little bit more to allow the balloon a complete and free inflation. So now it's okay. I'm going to unlock again. I'm going to test. It's a little bit deep. Do you agree? Yes. Probably here. Let me check a little test. Okay, I think it's okay there. So connect the pacing 180. and we wait for a good pacing. If not, we will have to change. 180. Okay, let's go, Carlos. Let's go, let's go. Full, 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 inflation, full. And pushing a little bit, deflate. Okay. Now give me the Amplats wire, stop the pacing. Stop. Important here, probably not as important as a self-expandable valve, where we instead of stop, we decrease pacing very slowly. She has some bradycardia before. She was on 47 or something like this. So I think it's almost okay. So now I can do a minimal test before pulling everything out, and then to check with Dr. Salmo. Let me pull the catheter out to have a better checking. Very slowly, I use this wire shape that I always perform. And let me do an answer here. Let's put, okay, it's okay there. Let's go. We have some paravalvular leak. Not too much, but let's check with echo. Pone AP y let's see what Dr. Salmon is observing with the echo. We will probably have to use one extra CC, but let's check with echo before. We still have a lot of time. Load it, because if we are not using it, it's not a problem. But in my opinion, one extra CC is going to be okay. The oversizing is going to be 12 or something like this. Is not too much. And she has so severe calcification.
Oscar, we have a wire inside the valve.
Yes, yes. The wire is still crossing the valve, so you might have some central leak.
Yes. Have a
Important to see we have paravalvular leak.
yes.
I saw something near the
We
septum.
only see a mild to moderate central aortic regurgitation, but
Not paravalvular.
I don't see yet
Okay.
a paravalvular leak.
So maybe we can do an additional angio, and then we will decide for to pull the wire.
Can you retry the wire?
Pone 20 de nuevo. Okay, let me check again. Vamos oblicuo a derecha. It's on the right view. Okay. Still have parallax there. Let's caudal. Más. More. Like this. Remember that we are doing TAVI cases asked by Dr. Samir in a way of preparation for TVT, which is starting today. No, I think it's central. You are right.
Okay.
So we don't have.
If you want to check again.
Okay. Let me on AP. Let me pull everything out. I will undeflect. And Carlos is gonna pull. I hold the sheath. And then I will introduce the pigtail. And then if everything is okay, we are going to close. And then we can move to the other lab. Any other question, Andres? Yeah. Balloons. Okay. So The question is, which is the advantage of self-expandable instead of over balloon expandable valves? So I could say that self-expandable is a better option when you have calcification or significant calcification on the LVOT. The next patient, in a way, is one example of this. This is a patient with a notch of calcium on the LVOT. So probably there is not a good idea of the balloon expandable valve. On the other side, heavily angulated aortas like this, I think balloon expandable with deflectable catheters are much better. Actually, on the instruction for use of the Evolut, 60 is over this. So it shouldn't be a good patient for self-expandable valve. A patient like this one with 60 degrees of angulation. Give me the amplas because extended are twisted. Give me a second. I don't know if we have any other situation where we rather like one or to the other. The other would be for valve-in-valve cases with the small valves. They are probably self-expandable valves will leave a little bit residual gradient. Another situation. If you have a low coronary ostium, probably balloon expandable would be okay because you can protect it a little bit better. So let's go to this caudal. Okay, gradient is here. So we don't have you see on the left of the monitor, we don't have any gradient. And diastolic is okay with a very nice notch that there. Or indentation. And here is a good position for the anancio. Let's check. Let's go, Carlitos. I think the outcome is okay. I shouldn't go too high with the oversizing. Remember that we were about 10 with half of cc less with the 23. And also we have a huge calcification. You can observe the calcium behind the stain frame. And I don't like to destroy the annulus before taking a plane for TVT. I think this is a very nice outcome. So I would ask Dr. Salmo to check again without anything crossing the valve. Give me a second. You can show the echo and we can close here while Dr. Fava is moving to the other room to start to prepare the patient. A little down. And I will close here with Dr. Joaquín. So, ¿lo puedes mirar, Fabián? Okay. So, regarding conduction system, we have almost the same than before. So the ACG, could you show the hemodynamics? Probably there you can see the ACG. We have probably a little bit of left bundle hemiblock, but nothing else. So Joaquin, so speaks French. Give me some light here. Any other question, Andres? So we have used only one ProGlide because we did echo-guided puncture. It's almost a normal femoral artery, huge. It is supposed to be sealed quite easily. No, here is okay because if not, we are destroying the image. Moving the table. Come here, Joaquin. Give me first the balloon. Yes. Yeah, I will cross with the balloon just in case. No more questions so far. Okay. Please, don't hesitate. We need your questions to make the live a little bit more interactive. If not, we become a little bit boring. So, which is the reason why we're still using this? Well, because for sure, if you have a huge problem, it can be easily solved by contralateral size. From radial approach, sometimes you don't have the stents, or you don't have such a long balloon to cover. Surgery could be an option. Show me. But in a way, what I mean is we are still talking about closure because no, móvelo, Calao, sácalo. Because closing or closure access is still an issue for TAVI. Not as frequent, can venir acá, but it's still an issue. ¿Revertiste un poco, Jaime? No, tenémelo. I'm gonna pull the E-sheath, and then I'm gonna introduce the 6 French sheath. Then I'm gonna tie the ProGlide. I will check how things are going on, and then I will decide where to use the 8 French angiostil. Aflójame. Lárgalo. Suéltalo. So as you can observe here, closing is almost okay. We don't have bleeding. But as we cannot revert completely the heparinization, I would rather like to use the angiosil here to be sure we are not going to have any problem. So hold it, give me the angiosil. Remember, this is a patient who had a bleeding complication. I don't like anyone more. So I'm gonna put the 8 French sheet, and then the angiosil, and then we will close the contralateral side, and we are done. Why I leave the 6 French sheath is to be sure I can cross the suture with the 8 French introducers sheath of the angiosil and not destroying the previous suture. Okay, I have backflow here and here. I'm sure I am in. Now I pull everything out. And as we are only 2, nobody is open this. We will invite somebody from the audience to visit us and help us on the procedures. Remember, this is Buenos Aires, you can come. I think Rich, who is helping us from Solta, with the monitors, is learning, and probably next year he can do it with us here in Buenos Aires. So for sure, everything is closed. We are closing here. Give me one more. Leave it here. Okay. ¿Qué va ahora, Joaquín? Give me the other angiosil for the other contralateral side. We are going to test to be sure everything is okay. Give me use Y connector. And then we will check it and to be sure that everything is okay. Let me put some order here. We have a previous boss here who always taught us to be everything in order, because he said that the table is in the same way than your head. If everything is not under control, probably you might have problems. Okay. So this is digital subtraction. Everything is perfect. So now we are going to pull this. Remember, once again, first you have to pull the wire, not to damage the carrefour, and then you close here. And then we might have 4 or 5 minutes before crossing to the other room. Once again, I stimulate to everybody for questions. Remember, the take-home message of this patient is how to solve a perforation that can occur whenever, always unexpected, sometimes expected. Yesterday we had a non-dilative lesion, we have to use cutting balloon at 20 atmospheres. Then we use rotablator because cutting balloon was not enough. Then we use high pressure balloons. However, the artery resists. But in this patient with the regular balloon, nominal with the stent, and using nominal pressure, we have a perforation. Yes. No, I think this is not the case because this is really mild, hacer un punto acá, really mild aortic regurgitation. So I think it's this patient is going to be in a regular follow-up, echo follow-up at 1 month, echo follow-up at 6, and then we will check everything. So Joaquin is going to tie this small hole here, or give me, I can do it for you before moving because we still have 2 or 3 minutes. And then he's going to retrieve the venous access and we will move to the other room. And probably you should hold here a little bit because the clopidogrel and so on. Comprimirlo después un poquito por si acaso. El venoso. Déjaselo un rato. Suturalo. We will leave the venous access just in case for a few hours and then we are done. So, Rich, I think we can close here because everything was done. Here you have to fix this. I would say thank you so much for following us during this case. I will change my scrub and move to the other room and where we have another patient prepared for you, another TAVI case. Bye-bye.